This module of our curriculum will discuss strategies for program design that can be applied across clients and populations regardless of fitness level or health history. It is imperative that fitness professional review a comprehensive health history, gait and motion analysis utilizing the principles and concepts from our previous discussions. The fitness professional must use discretion of the approach they will use with their clients based upon the limitations, compensations, and idiosyncrasies discovered from the health history and gait and motion analysis. It is highly suggested that a regressive to progressive mentality be maintained to make sure there is adequate and efficient movement from the big movement rocks, that being foot and ankle complex, hips, and thoracic spine. Remember, there is no one method that is suggested in this module. Rather, program design is an art based upon science. In September 2010, a study was performed by Drs. Jan Schroeder and Sean Dolan for IDEA, the 2010 IDEA Personal Training and Equipment Trends from the IDEA Fitness Journal in September of 2010. This study was researching why people use personal trainers and the needs those clients have. The following is a summary of their efforts. 72% of senior fitness uses a personal trainer. 33% of clients are between the ages of 45 and 54 years of age. 25% of clients are in the 55 to 64 age group. The two previous categories comprise 58% of those who use personal training. They're baby boomers, have ancillary income, and want to reduce the risk associated with the aging process and lifestyle-related disease. This presents wonderful opportunities for trainers, whether the objective is fitness, risk reduction, or corrective exercise. 21% are age 65 and older, but the most astonishing statistic is 84% of those using personal trainers have chronic injury. This group poses the greatest opportunity for trainers, especially if they have a good understanding of human movement. Remember, the site of the injury is not the problem, it's usually the symptom. If trainers can develop and appreciate human movement, they will be able to free up the limitation and strengthen the compensatory motion and reduce the symptoms and enhance healthy tissue healing. In the numerous gait and motion analysis that I've done over the years, I found certain common limitations that people possess when they come for evaluation. Often many of these lead to some dysfunctions, lead to injuries. And what we have to do is kind of look at these common limitations and identify what they are and clean them up. One of the most common limitations that I see is limited dorsiflexion. We talked about this earlier in movement, but if we cannot get good dorsiflexion through the ankle and we can't get it through the forefoot, you are not going to load the system through the sagittal plane, which will then won't allow you to get adequate rotation in the transverse plane, which then affects the ability to load in the frontal plane. So we need to make sure that we have good dorsiflexion through the metatarsal heads and especially through the ankle, and especially through the great toe. So that entire foot complex needs to be loaded. I often see tight hip flexors of the same side and the same side calf get tight. Now one affects the other. If you don't have the ability to go through good dorsiflexion, you're going to limit the ability to go through hip extension. Likewise, if you're tight in the hip flexor and you can't get through good hip extension, you're going to limit the ability to have good ankle dorsiflexion. So one affects the other, and really when you stretch, when we look at the flexibility highways, we need to make sure that we stretch both the same side calf and the same side hip flexor together, because one can turn off the other. Many times people have come to me and said, I feel tight in the hip. I get them on a table and check their hip flexors, and they are just fine. But I find that it's really the calf that is tight, and they have the difficulty getting through the hip. And one can affect the other. Likewise, a tight hip flexor can affect the opposite shoulder. We talked about in flexibility highways, the anterior X factor that goes from the opposite hip across the obliques through the pec to the opposite shoulder. And we can see this in the respect that if you're tight in the hip flexor, which could also be affected by the calf, but if you're tight in the hip flexor, you are not going to have as much extension and rotation to the opposite side. In other words, the opposite shoulder won't extend as far, and you won't rotate to the opposite side as far. So we need to make sure that we look at that relationship and not only work our clients, but mobilize our clients and then strengthen the ability to control from the opposite hip to the opposite shoulder. One of the most common limitations that I see, particularly amongst runners, cyclists, swimmers, multi-sport athletes, people who have had ankle problems, people who have had knee, hip problems, or knee or hip surgery, or the sedentary, or the elderly, is the lack of loading in the frontal plane, what we commonly have been referring to now as the lateral flexibility highway. If you cannot load in the frontal plane and get good hip adduction, you are going to limit the ability to rotate to the other side. You're going to limit the ability to have internal hip rotation. In fact, if you just adduct the hip and just do a toe step to see how much rotation you get into that hip, and then slightly AB duct that hip and rotate, you're going to see that the pelvis won't rotate as effectively into internal rotation of that hip. So we need to make sure that we have adequate motion in the frontal plane to allow rotation to the opposite side, to allow loading of the opposite side, to allow extension of the opposite side. So we see loading of this side is going to affect unloading of this side. If this is tight, this will stay loaded for a bit longer. So again, a common limitation that I see is lack of frontal plane motion through the hips, which will affect sagittal plane motion, which will affect rotation. The study of the adductors over the course of the years, I have greatly appreciated how powerful the adductor complex is and how much pelvic dysfunction and SI joint dysfunction they can create. We must make sure that we have good rotation and good lengthening, eccentric loading of the adductors. Now notice I said rotation. The adductors do not adduct the hip in gait and in upright functional movement. If we go side to side, if we do a side lunge as an example, this adductor is going to lengthen eccentrically to decelerate hip abduction. But we don't walk like this. We walk in a pattern, obviously with a contralateral reach, but this hip that is extended, the adductor of the extended hip is helping decelerate hip extension and external rotation. The adductor of the lead leg of the flexed hip helps decelerate hip flexion and internal rotation in gait and in motion. If they get tight, if the adductors get tight, it's going to limit the ability to get through the hips in the transverse plane. It's going to limit the ability to load the hips in the frontal plane, but it's also going to have a huge impact on your inability to get into good sagittal plane movement. So the adductors really work in 3 planes of motion. Extremely powerful, but make sure that we get the motion, that we get mobilizing through sagittal, frontal, and transverse planes, so we get them loaded and lengthened in all 3 planes of motion. Likewise, we talked earlier, what is the pelvis doing in kyphosis? You see somebody that is kyphotic, the pelvis is going to go into a posterior pelvic tilt. You're going to see that the femurs will go into a slight externally rotated position. You're going to see the lumbar spine flex, thoracic spine flex, shoulders protract, cervical spine flex, head goes forward and down. So our kyphotic posture is affecting the entire chain. It is not just affecting the thoracic spine. We need to make sure that we address the thoracic spine, but also the pelvis, because one affects the other. If you're kyphotic in the thoracic spine, it's going to impact the pelvis into a posterior tilt. If you're tight in the hip flexors, if you're tight in the abdominals, and it's creating a posterior pelvic tilt, it's having an impact on the lumbar and thoracic spine as well as the cervical spine. And also the last common limitation that I see is a tight shoulder girdle. Anytime that shoulder girdle, I'm talking about not only the glenohumeral joint, I'm not talking just about the humerus, I'm not talking about just the clavicle and its motion at the sternoclavicular joint, but I'm also talking about the scapula and its ability to glide on the ribs. That entire shoulder girdle, when it becomes tight, will impact gait from the top down. In other words, when we see motion such as this, or we see motion that's this, and we see that this shoulder is able to get into extension, you're going to see retraction of the scapula. You're going to see the rotation to the opposite side or the side of the extended arm. But if you don't have that motion, the scapula is not going to move as well. The scapula is not going to retract as well. You're going to see there's going to be limited rotation to that side of the extended arm. And we start to see tightness develop through the entire chain, especially through the transverse plane. So those common limitations, we need to address them to enhance proper function, to enhance proper performance, and allow the entire system from the foot all the way up to the thoracic spine to operate and to have optimal performance.
After years of trying to understand human movement, I realized there are 4 big movement rocks within the body that must have adequate range of motion to ensure proper function and reduced risk of injury. When I think about the 3 most common injuries suffered in society, that being low back pain, knee pain, and shoulder and neck pain, often these are results from immobility in one or more of the 4 big movement rocks. If you look at these injured regions, each one is between the big rocks regions. For example, the knee is between the foot and ankle complex and the hip. The low back is in the midst of the hip and the thoracic spine. The shoulder is dependent upon good mobility of the scapula, which is dependent upon the action of the thoracic cage, which is dependent upon the action of the hips and the foot and ankle complex. If the 4 big movement rocks can be mobile and move in all 3 planes of motion, there will be a significant reduction of the 3 most common injuries: low back pain, knee pain, and shoulder girdle and neck pain. When describing movement away from the spine, we need to view the relative position of the bone segments that make up the joint. Movements away from the spine are described as the distal bone in relation to the proximal bone. For example, in the left photo, notice that the left femur is adducted to the ilium as the left leg is moved to the right or adducted. In the right photo, see how the left leg is adducted to the ilium even though the left picture shows the leg further to the right. Do not be confused by the fact that the motion is an open chain. The left picture has the foot off the ground, yet the femur is still adducted to the left. Once again, movements away from the spine are described as the distal bone in relation to the proximal bone. In this case, both pictures show there is adduction to the pelvis. However, in the spine, the rules change. In spinal movements, they are described as the proximal segment in relation to the distal bone segment. For instance, the left photo demonstrates the head turned to the left, which in reality positions the upper cervical vertebra rotated further than the distal vertebra, thereby describing left cervical rotation. This motion, this position and motion, is a top-down action. In the right photo, the head is forward, but the lower vertebral segments are rotated to the right, which is, in actuality, by its definition, places the cervical spine into left rotation. Remember, we're looking at movement as described as the distal bone in relation to the proximal bone. It is essential for the students of human movement to understand this concept, as it will be important to allow the proper joint movements, especially if working with an injured or sedentary population. Often with these clients, the trainer needs to create an environment for success, and at times we may have to pre-position the clients into certain joint positions and perform remedial movement patterns prior to commencing with more advanced progressive actions. Both, in this case, are left cervical rotation.
All muscles, all joints work in 3 planes of motion. The books don't tell us that. This particular slide to me is my most important if I want to appreciate and understand how the body moves from the ground up and the top down. To me, this is the roadmap to unravel the complexities of what goes on in the body. What this shows is each joint that works in 3 planes of motion, the sagittal, frontal, and the transverse plane, and how each joint works within each plane of motion, but also how it's dependent upon other joints above and below. For example, let's look at the knee. To load the knee, we see that the knee in the sagittal plane will flex. Everybody knows that. However, what we have to also understand is that as the knee goes into flexion, take a look at what's happening at your ankle. Don't look at the slide. Take a look at what's happening at your ankle. You see that your ankle is dorsiflexed. Forget about the PF for the moment. Just look at dorsiflexion. So we see, to make the knee successful, to create an environment for the knee to be successful, the ankle has to dorsiflex. Let's just test it for a moment. Draw your knee behind your shoelaces as an example, and try and do your squat or your lunge now. You see that this isn't a very successful squat or a lunge. But in order to make the squat or the lunge successful, the ankle must go into dorsiflexion. When I see clients who tell me their physician or their physios have told them not to squat, the first question I have to ask is, why? One of the first things I look at is what is going on at the foot and the ankle complex. Because to me, the knee is the dumbest joint in the body. It's going to greatly depend upon what goes on at the foot and ankle and what goes on above at the hip. So we see in the sagittal plane, as the knee flexes, it is loaded. Or as the knee loads, it goes through flexion. Now, find your tibial line. Find the tibial line, or what we commonly call the shin bone. As you go into knee flexion, under normal healthy conditions, we're not talking about a flat foot or a high arch foot. Under normal healthy conditions, the tibia goes into internal rotation, it rolls in. By definition, if you recall in our previous slides, movement is described away from the spine as the distal bone in relation to the proximal bone. So in this case, we see that the tibia is rolling in, tibia is distal to the femur, and we have internal rotation of the tibia. In the frontal plane, everybody imagine you're a marionette. I'm holding your strings, and now we let go. As you collapse down, notice where the knee goes. The knee joint moves towards the midline, but don't be fooled by that. Look at the distal end of the tibia in relation to the distal end of the femur. We see that the tibia is lateral to the femur. Therefore, by definition, distal bone in relation to the proximal bone, the tibia is lateral or abducted to the femur, the knee is abducted. To make the knee successful in all three planes of motion, we have to go through knee flexion in the sagittal plane, knee abduction in the frontal plane, and internal rotation in the transverse plane. Let's move up to the hip for a moment. We see that as the knee is flexed, the tibia has gone into abduction. The femur is in internal rotation. The femur is flexed to the hip, so we see that the femur in relation to the ilium is flexed, so the hip is flexed in the sagittal plane. The femurs have gone into internal rotation in the transverse plane. And when we look at the femur, the distal bone in relation to the ilium, we see that the hip is adducted. So in order for the knee to be successful, the hip better be doing its thing and become successful. And a lot of this is dependent upon what goes on at the foot and the ankle complex. We'll talk about the big movement rocks with the foot in another slide. But again, we need good ankle dorsiflexion to allow the knee to flex, to allow the hip to optimally flex and load and internally rotate and adduct to load the glute, to flex, internally rotate, and abduct to load the knee. This slide is my most important slide. This is my roadmap for success. Anytime I do a gait and motion analysis, anytime I'm watching people do any type of activity, I must keep this slide constantly going in my mind. When I was first starting to study movement, and I'm still studying movement, I took this slide, I went in front of a mirror, and I was just moving around. I was reaching, I was squatting, I was lunging, I was building various movements, and I would stop to see where one joint segment is in relation to another. I highly suggest that you do the same. Don't try and memorize the slide. It will not mean anything. We need to internalize it. We need to feel it. We need to understand from a distal to a proximal approach and also a top-down approach of how motion is going to affect joints. You can do this. Good luck. And again, if you appreciate this, if you start to internalize this particular slide, it will open up an entirely new paradigm of how you will look at people, how you will analyze people, and how you will create program design. Many of the programs, many of the curriculums, many of the textbooks that talk about fitness programming, talks about program design, really doesn't take into account what goes on at the foot. If we think about it, the foot is the conduit between the ground, and the foot's going to react to ground reaction forces as well as gravity pushing down on it. The foot has 33 joints, 26 bones, 24 muscles. And those muscles want to be eccentrically loaded first. They will stabilize and then concentrically unload. We have to understand what goes on at the foot. Because I'm a firm believer that if we have foot dysfunction, we're going to see dysfunction throughout the entire kinetic chain. I've seen many cases, people with knee pain, hip pain, low back pain, have a foot issue, a foot problem. In the fitness industry, I believe we just need to understand four major components. If there's any pathology, we must refer that out. But the four major components is understanding what is going to happen at the foot to create an environment for the entire system to become successful. Those components are, think of it this way. As the foot hits the ground, gravity is going to take the foot and drive it into the ground. But to make the system successful, to turn on the glutes and to make the hips function properly, to make the low back function properly, what the foot must do is go through calcaneal eversion. As you go through calcaneal eversions, the foot again hits the ground and the foot starts to flatten out as we dorsiflex into mid-stance. Calcaneus is going to evert and the tibia is going to internally rotate. You look at it from the side, you're going to see the foot hit the ground. Dorsiflexion occurs as the hip goes over the foot. Look at it in this respect. Foot hits the ground, hip moves over the foot, undorsiflex at the foot and ankle complex. So we have calcaneal eversion, dorsiflexion. That is going to cause tibial internal rotation. Think of it this way. You have the calcaneus, and you have the talus that sits on top of the calcaneus. Think of the talus as a rider on a bicycle. As that bicycle starts to lean one way, the bottom of the tire goes outward. Think of that as pronation, because pronation is the bottom of the calcaneus is driving laterally. But the bone itself is driving medially, but the bottom, which is the tire, is driving laterally. We look at it in this respect. So as that happens, the talus is going to dive in, because you as a bike rider, as your bike starts to tilt, you're probably going to look to see where you're going to go. Now on top of the talus, think of a long helmet. That long helmet is called the tibia. As you as the talus turn one way, that helmet is going to turn with you, and the tibia is going to internally rotate. So we have three components going on so far. We have calcaneal eversion, dorsiflexion, tibial internal rotation. Now here's the last concept, and that's forefoot abduction. If you recall, when we look at movement away from the spine, we look at the distal bone in relation to the proximal bone. In other words, we see that the long bones, the tarsals, and we see the phalanges are going to go abduction or lateral to the calcaneus. But there is no real motion, such as the arm right now is going into abduction. There is no real movement, but relative movement when we go into forefoot abduction when the foot hits the ground. And the reason I say that is as the foot hits the ground and the calcaneus dives in, remember the calcaneus is moving probably further and faster than the forefoot, creating forefoot abduction. So in reality, we have relative forefoot abduction as the calcaneus moves medially. So as a review, the four big rocks that we need to make sure the foot is going through is calcaneal eversion, dorsiflexion, tibial internal rotation, and forefoot abduction. If any one of those components gets limited in motion, you will see that the system is going to become limited in motion, and that's when we often develop compensations. Once we get those motions, and the tibia internally rotates, and the knee is going to abduct, and the knee is going to go through internal rotation, and the femur will internally rotate, and the femur will abduct, and then we flex. The gluteals are maximally loaded in three planes of motion. That occurs all because of the success that has been created by the foot.
As a review, calcaneal eversion, dorsiflexion, tibial internal rotation, forefoot abduction create eccentric loading to maximally recruit the gluteal complex. I've received many questions regarding how to blend the traditional training program with a functional integrated movement pattern. When I discuss triplane movements, programs, and strategies, I never want to say do not do the traditional movements such as a squat, Olympic lifts, or selectorized weight training machines. I believe they have a role in a comprehensive program design, particularly for hypertrophy and strength development. However, I also see these modalities have limitations such as movement in primarily one plane of motion. Machines are often concentric action before eccentric unloading. Traditional exercise is often isolated and not integrated in nature. And most often, the traditional training programs are in the sagittal and frontal planes and limited in the transverse plane. I do believe there can be an effective plan utilizing both the traditional approach with a functional integrated triplane training program. The principles I follow are first concentric, then eccentric. Keep in mind, this is opposite of how the body moves. Physiologically, we go through eccentric, we stabilize, then concentric unload. The rationale is that concentric will shorten the tissues, but also does promote hypertrophy and strength gains. I do the traditional action first, then add a complementary triplane integrated movement pattern to the traditional movement. This may be immediately after the traditional exercise or sometime before the program is over. This allows the tissue to lengthen in 3 planes of motion, go through the eccentric phase, which is physiologically efficient. Isolate, then integrate. This follows the same principles above. Think of isolation as the link in a chain. At some point, you must put that link back into the chain. So I will do the isolated movement pattern first, then follow either immediately after or sometime in the program design an integrated movement pattern. Go rotational first. If the majority of the program is performed in linear planes, the risk of fatigue becomes greater when we start to do transverse plane movement. We learned in part 1 it requires pure muscle function to decelerate movements in the transverse plane. In fact, the majority of injuries occur due to the lack of eccentric strength and control through the transverse plane. Therefore, I often perform many warm-up patterns that require predominantly transverse plane motion to be done when the client has sufficient energy to control the movement pattern. Heavy, then to functional threshold. It is easier to control the mass when it is closer to the midline than further away from it. Using the concept of triangulation, I will perform heavier weighted movements first, then add a complementary action that is away from the midline and adds the variables that affect the vertical and horizontal angulations, as well as variable speed, repetitions, order of the exercise, and rest duration. If I am working with a client that has had a recent injury or sedentary, then I follow the following process. I'll do a muscle energy technique first, followed by the traditional exercise, then an integrated triplane action. This has proven to be a more successful approach with the various populations I have served. Remember, program design is an art based upon science.
Imagine this scenario. You see a client working with their trainer. That client is doing a squat. The squat is being done with many commands, many cues, because the trainer is telling the client, make sure you stick your chest and your hips out in opposite directions. Stand tall, have your head look up. Now when you squat, make sure your knees are over your second and third toes. Take a deep breath in, exhale as you go out. Drive your midfoot, drive your heel to the ground. Keep one thing in mind, your clients most likely are probably new to fitness and exercise, or they're deconditioned, and they're probably a bit intimidated, a little bit uncomfortable with their trainer, because their trainer has a lot of expertise, their trainer is in shape, and none of us like to be in a position where we feel a little bit inferior. So now that client comes to the trainer, and the trainer starts throwing out all these cues and these commands. that client is going to start thinking there's too much for me to think about here. Let's make it simple. If we recall, one of the criteria to human movement is that movement and function is subconscious. We need to make our cues very simple so it takes care of a lot of the other ancillary things that go on, such as having to stand tall, stick the chest and the butt out in opposite directions. There's an easier way to do it, and there's only 3 cues that I use for any of my clients. Let it be if it's somebody who is remedial, somebody who is in rehab, or my highest level athlete, only 3 cues. The first one, stand tall. From the greater trochanter to the top of the head, reach the head to the ceiling, reach the head to the sky. Because the majority of people have a bit of kyphosis, natural, just deconditioned, round-shouldered kyphosis. You look at somebody in this position, you're going to see that the hips are slightly posteriorly tilted, flex the lumbar spine, flex the thoracic spine, the head comes forward, the cervical spine is flexed. But if we just tell them from the greater trochanter to the top of your head, reach your head to the ceiling, then we get this relative anterior pelvic tilt. You get extension at the lumbar spine, you get extension at the thoracic cage, you get extension at your cervical spine, the scapula retracts, the head goes back into a more neutral position. Stand tall. You can even just tell your client, get into a stand tall position, now go and do your squat. Versus being a bit kyphotic and now you do the squat. There's a difference on the stress in the system, particularly at the hip, particularly at the low back. First cue, stand tall. Secondly, imagine there's a flashlight in your navel. I call it the beacon of life. Anytime that you rotate, anytime that your client has to do rotational movements, shine that flashlight, shine that beacon of life around the room. The rationale for this is that where the pelvis goes, the low back will follow. So I want to keep my pelvis and my thoracic cage mobile. If I can get that mobility in these 2 regions by shining the beacon of life around the room, you're going to see where the pelvis goes, the low back will follow. And even those with back pain can do movement patterns as long as we can get the mobility in the hips, as long as we get the mobility and the movement through the thoracic cage, where the pelvis goes, the low back will follow. The third cue, reach with your scapula. If we watch, I'm just reaching right now with my arm. There's very little thoracic motion, there's very little reach. But if I reach with my scapula, where the scapula goes, the humerus will follow. You'll see there's more thoracic rotation, and I'm able to get the abdominals loaded, I'm able to get the thoracic cage loaded, I'm able to get the hips more loaded than just reaching with an arm. Many times we have taught our clients when they do a chest press, when they do a shoulder press, keep the scapula retracted. But if I reach up into a cabinet with a retracted scapula, you're going to see the reach is not going to be that far. The reach is not going to be that efficient. There are about 19 muscles that attach to the shoulder girdle, and they're just like any other muscle in the body that want to go through an eccentric load first, stabilize, and then concentric unload. So when we reach with the scapula, what you're able to do is get those tissues to play in the game and be able to eccentrically load, stabilize, and concentrically unload. So there's a quick review. Stand tall, shine the beacon of life, particularly through rotational movement patterns, and reach with the scapula, because where the scapula goes, the humerus will follow. When I can't get to any of my facilities, sometimes I'll just jump into the garage for a bit and get a quick workout. I have limited equipment, using the Viper and dumbbells here. But if you notice, what I did, I was able to have short movements versus longer movements further away from the body, lower movements, upper movements away from the body. We can use verticality, and we can use horizontal angulation to increase the stress on the system when we're limited in equipment. Typically, and historically in our industry, we stayed pretty much aligned close to the center of the body, close to the spine. But the further we go away from the body, the further out away from the body. You can do a lunge, or you can do a lunge. You can do a lunge, and you can do a longer lunge. So we can use the horizontal and vertical distances to increase the stress on the system. So keep in mind, not only do we want to use our weight, our body weight, and the external equipment, but consider the component of verticality, height from the ground up, and also distance and a horizontal angulation away from the body. So when you look at this triangulated arrangement, you're limited by your creativity of how you can stress the system. If you're holding a weight, such as a dumbbell, and the more vertical you go, you're going to load the system in the posterior side, posterior flexibility highway. But we can limit it from floor to hips. You can go from floor to hips to shoulder and overhead. And that way you can limit, or I should say, you should be able to stress the system anterior, posterior, do rotational movements, use something like a Viper, where you can have a more remedial pattern with just tilting series to a more of a lunging series. The further away you go from the center of your mass, the further up you go from the ground, the more demanding you'll be able to place on the system. And that's a variable that you can use. And as the trainer, you're limited by your creativity. Just base the movement based upon the verticality, based upon the horizontal angulation, base it upon your client's limitations, compensations, and idiosyncrasies. And that way, any program can be as quick, can be as demanding. You don't need a whole lot of equipment. You see I'm in my garage, but I guarantee you I can get a great workout. When I look at movement, I think of life as a big tic-tac-toe board. In the United States, it's referred to as a tic-tac-toe board. In Australia, and I believe the UK, it's referred to as knots and crosses. When I think of tic-tac-toe boards, we have 2 lines that come across, 2 lines that go horizontal. We have 9 squares. 1, 2, 3, 4, 5, 6, 7, 8, 9. I think of those boards not only on the floor, but overhead, in front of me, behind me, to the sides. When I think of those boards, I think of the movement spectrum. I think of the different foot positions and different arm reaches that we can create. When we think about this, in the sagittal plane, you can be in a neutral stance. You can be in a narrow neutral stance. You can be in a wider neutral stance. We're in a neutral stance, or you can be in a staggered stance. So when we're in a neutral stance, we can be neutral, we can be staggered. In the frontal plane, you can be narrow, or you can be wide. Now when you combine sagittal and frontal, you can be staggered and wide, or you can be staggered and narrow. In the transverse plane, we can be either internally rotated or externally rotated. So you can be neutral, internally rotated, externally rotated. You can be narrow, internally, externally rotated. You can be wide, internally or externally rotated. Or we can be staggered, long, externally rotated, internally rotated. So when we place our feet in these different boxes of the knots and crosses or the tic-tac-toe board, all of a sudden there's a different reaction through the foot, into the hip, into the thoracic spine, even through the low back into the thoracic spine. And now think of it overhead that you go and reach at these various boxes and various patterns. Now you have a limitless program design of exercises. Your exercise toolbox becomes very deep. But at the same time, what we're doing is mobilizing tissues from the ground up, but also from the top down. We can take a squat as an example. Most people do a bilateral squat. But if you do a long, wide, externally rotated or internally rotated, and now you squat, your entire system is taking on a different reaction just based upon this particular movement spectrum. So try it. Very effective, helps people become more mobile, but yet it strengthens them because the mobility and stability are dependent upon each other. Even though they're opposite ends of the movement spectrum, they're still part of the same movement continuum. Whatever your impression is, whatever your perception is of the core, it goes well beyond the abdominals and the hips. I believe the core starts from the floor. In fact, I believe the core starts from the great toe. If we look at this, I believe the absolute friends of the abdominals is the hip flexors, the calf, the great toe, and the shoulder girdle. Because when we walk, we're in this contralateral reach. When you get into this contralateral reach and you have your hip extended, the pelvis goes into anterior pelvic tilt. The pelvis of the extended hip goes into an anterior pelvic tilt, which lengthens the abdominals in the sagittal plane. When we have a contralateral reach, you see that the thoracic spine is rotating one way, the pelvis is going another way. Looking at it straight on, you've got rotation to the right in this case, and the pelvis is rotated to the left, which lengthens the abdominals in all three planes of motion, especially in the transverse plane. Then as you start walking and propel off of your great toe, you get further hip extension, which is further going to load the abdominals in the sagittal plane. But once we get into mid-stance, what we need to do is be able to keep our eyes upright. If we didn't, then this hip hikes, we would be leaning to the opposite side, but our tendency is to keep our eyes and our head level to the ground, which lengthens the abdominals in the frontal plane. So now the abdominals are loaded in all three planes of motion. If you have any limitation in your ankle, if you don't have good dorsiflexion, you will not be able to go through good hip extension, which is then going to limit the ability to load the abdominals in the sagittal plane. But if you don't have good hip extension, that's going to limit your ability to load the abdominals in the transverse plane, which will now shorten the stride, and you're not going to load the abdominals in all three planes of motion, and especially in the last of the frontal plane. So what we need to do is make sure that we have good mobility in the great toe, the calf, and the hip to allow rotation, and good thoracic motion to allow rotation, so we can load the abdominals in all three planes of motion. The absolute friends of the abdominals, the way I look at it as we start from the ground up, is good mobility in the great toe, good motion in the ankle, good mobility in the hip flexors, and good mobility in the thoracic spine, good mobility in the shoulder girdle, because that will load the abdominals in all three planes of motion, and then we've got the absolute friends of the abdominals. Great toe, calf, ankle, hip, thoracic spine. The body is an integrated relationship, integrated matrix of tissue from the ground up as well as the top down. And we also know that change in body angles or reaches has an impact upon what goes on from the top down or the bottom up. Many times clients present, and when they do a squat, their knees go into a valgus moment, or when they do a lunge, the knee dives in. And so many times I see trainers trying to correct that, trying to either hold the knee back or they'll take a band and drive the knee outward. But really, think of it this way, the knee is the dumbest joint in the body and is greatly impacted by what goes on at the hip and the foot. So when I see clients that come in that have a valgus moment, I have to sit back and think why. In many cases, the foot may be a flat foot, and remember the knee is going to be greatly influenced by what goes on at the foot. So if somebody has a flat foot, and when they squat or lunge, the knee dives in immediately, or the knee goes into an abducted moment, we have to understand that if we have a client who has that position or that type of reaction, if we have them reach to the same side lateral, in other words, the right leg is forward, a reach to the same side lateral will enhance calcaneal inversion, reduce the amount of dorsiflexion, so they'll go into a relative plantar flex position, but the tibia is going to externally rotate and the knee is going to line up better over the second and third metatarsal heads. I want to make this a subconscious reaction. I don't want people to think, keep the knee tracking over the second and third toe, because the knee may not want to do that. But if I see that we can do a lunge with the same side lateral reach, you're going to see calcaneal inversion, tibia is going to externally rotate, less dorsiflexion, the forefoot with AV duct. Likewise, somebody may have a a high arch foot. And when they do a squat or a lunge, the knee wants to track laterally. If you do an opposite lateral reach, that will enhance calcaneal eversion, dorsiflexion, tibial internal rotation, forefoot abduction, and you're going to see the knee will track more over the second and third toes, as for some reason the goal seems to be. I'm not overly concerned of where the knee goes. I'm more concerned of why it goes that way and how it comes out of that reaction. So again, same side lateral reach will enhance calcaneal inversion, less dorsiflexion, tibial external rotation, forefoot adduction. Opposite lateral reach will enhance calcaneal eversion, dorsiflexion, tibial internal rotation, forefoot abduction. If we have an overhead reach, it's going to keep it's going to keep the foot and the subtalar joint relatively neutral. You get into an anterior reach, you're going to get more of a sagittal plane effect because of the lengthening on the posterior flexibility highway. So reaches can be extremely effective to modify or to tweak the desired reaction of either a squat or a lunge. Historically, when clients have presented with kyphotic or round-shouldered posture, historically the fitness industry and the physio industry has addressed strictly the thoracic spine. But if you think about this, when we're round-shouldered, this is going to be an entire chain reaction. So what I'd like you to do for a moment is stand tall. From the greater trochanter to the top of your head, reach your head to the ceiling and stand tall. You'll notice that you have your lordosis. So what I'd like you to do is place your hand at your low back and one hand on your pelvis. Now become kyphotic. You will notice that as you become kyphotic, you flex at the lumbar spine, you flex at the thoracic spine, your shoulders are protracted, your cervical spine is flexed, and your head has come forward. But one thing as well, if you go from this position, stand tall again, you go from this side, you go from a kyphotic to to a stand tall position, your pelvis goes into a relative anterior pelvic tilt. When we do become kyphotic, you will see the pelvis also goes into a posterior pelvic tilt. So kyphosis is not only affecting the thoracic spine, it's affecting the pelvis as well. Or if you have somebody who has a posterior pelvic tilt, it's also going to flex the lumbar spine and create relative thoracic flexion. Some strategies for this in the past have been just stretch the pec and strengthen the posterior shoulder, but we have not addressed that. What we really need to do is have your client stand tall. To whatever capability they can, stand tall. From the greater trochanter to the top of your head, reach your head to the ceiling. Next is get into a staggered stance. If you will notice, as you get into a staggered stance, the extended hip now goes into an anterior pelvic tilt. You can then take a band or a tube or a low cable row, start low, stand tall, but reach forward, grab that band, cable, low cable row, and just reach to your hip height posterior side. As you do so, you're going to bend forward again. You're going to get into actually more kyphosis. Reach back, rotate the hip. Remember the beacon of light. Shine the beacon of light into the lead leg. Rotate the hip as you reach posteriorly. What you'll see as you reach posteriorly, you're getting a stretch of the pec, actually getting a stretch of the pec into the opposite hip. And you're also getting retraction of the posterior shoulder girdle. The objective has always been to stretch the pecs, strengthen the backside, but we've never addressed the pelvis. Unless if we get the pelvis into a relatively anterior pelvic tilt, you will not gain the lordosis back. So what we're saying here, what we're suggesting is get into a staggered stance, anterior pelvic tilt, reach forward, and reach back. You're going to see that we're able to address the kyphotic posture, but not through the sagittal plane. You're going to gain success through the transverse plane. We stretch the anterior side, and we strengthen the posterior side. We've stretched the anterior X factor, the flexibility highways, and we're strengthening the posterior flexibility highway as well as the posterior X factor on the opposite side. So when we think about this, kyphosis is not just a thoracic problem, it's a pelvic problem as well.
And we cannot clean up, we cannot have improvement in the posture unless we adjust both thoracic spine as well as the pelvis. We've already discussed flexibility highways quite deeply in Module 2. This will be a rapid review as we need to have good flexibility, understand the flexibility highways as it relates not only to the stretching but also to the movement patterns that make up the program design. The anterior flexibility highway runs from the anterior tibialis north to the distal quadriceps. The quadriceps attach to the hip flexors that connect to the abdominals. The abdominals run northward and merge with the obliques, pectorals, into the cervical flexors. If the position of the arm is flexed and or abducted, the anterior flexibility highway includes the upper extremity. Having good range of motion of the anterior flexibility highway will enhance extension movements. The posterior flexibility highway begins at the plantar fascia connecting to the calcaneus to the Achilles tendon. The calf runs from the Achilles north with the gastrocnemius attaching at the femoral condyles. The gastrocnemius merges with the hamstrings that attach below the knee and wrap around the tibial condyles. The convergence of these tissues form what I call the trapeze artist of the body. The hamstrings run north and attach proximately at the ischial tuberosity via the sacrotuberous ligament attaching at the sacrum. These tissues merge with the sacral fascia, meeting with the lumbar fascia, and connect distally with the erector spinae. The erector spinae travel north and proximally attach to the occiput to the cranial fascia to the forehead. Good range of motion of the posterior flexibility highway enhances flexion moments. To enhance lateral motions in the frontal plane, there must be ample range of motion along the lateral flexibility highway. Starting at the perineals, traversing northward, there is a convergence at the lateral fibular head with the fibers of the iliotibial band at the lateral tibial condyle. The iliotibial band continues northward to conjoin the tensor fascia lata. The TFL merges with the lateral glute complex. As the lateral gluteals meet the quadratus lumborum, obliques, intercostals, into the latissimus dorsi, into the shoulder girdle, the lateral flexibility highway is crucial to not only allow adduction moments, but will improve internal hip rotation of the hips. When viewing the adductor complex, the fibrous alignment runs from the posterior femur medially to the pubis ramus. The fascia is a close neighbor to the rectus abdominis and the external obliques on the opposite side. The external obliques meets the serratus anterior into the pectorals to the opposite shoulder. To allow efficient movement of extension and external rotation, the anterior X factor must be stretched together in order to get that motion from the hips and shoulder girdle and not through the low back. View the musculature from the back and notice the fibrous alignment of the opposite latissimus dorsi and gluteal complex. The posterior X factor has a parallel line along these soft tissue structures that converge through the lumbar fascia. Possessing good range of motion along the posterior X factor will improve movements requiring internal rotation and flexion. The turnpike connects the opposite posterior cervical spine to the opposite scapula, wrapping around the back to the same side hip. The scalene and capitis cervicus attaches to the rhomboid to the opposite side of the spine. The opposite rhomboid connects to the medial 30% of the anterior surface of the scapula and merges with the subscapularis. At the lateral 20% of the scapula, the subscapularis conjoins the serratus anterior, which wraps around the side of the torso and unites with the external oblique. The external oblique fibers run diagonally towards the opposite hip. The turnpike forms a relationship with the cervical spine to the hips, especially when rotational actions are required involving the head, shoulder girdle, and hips. When we put all this together, what we have to think about is when a client presents, we need to do some type of dynamic warm-up for 5 to 15 minutes, depending on the condition of the athlete or the client. Walking on a treadmill, low-level jogging, Z patterns, karaoke, side-to-side hops, figure 8 walks, figure 8 runs, diagonal movement patterns, lunges, hops, jumps, and many other types of movements can be used as a dynamic warm-up. This will increase body temperature. This will increase the viscosity of the soft tissues and allow movement to occur more efficiently. The rationale for our warm-up is to make sure that we get good range of motion through the big movement rocks, foot and ankle complex, hips, and thoracic spine. After we do a dynamic warm-up, we'll start into the program design itself. Much of this is comprised of triplane movement patterns, gradually increasing range of motion with each repetition. If we're going to do traditional movements, we will do those first and then blend the functional integrated triplane movements into that program design, do the entire program, and then that will lead to a post-workout stretch, which is static, triplane flexibility highway model. Hold each position for 20 to 30 seconds. Perform 2 to 3 repetitions each. We must regress before we progress. We must develop a mentality to capture the essential movements that come from the 3 big movement rocks. The following slides are going to demonstrate part of a remedial warm-up that can be incorporated with the overall dynamic warm-up. What you will notice with the deconditioned people, with the deconditioned clients, deconditioned athletes, or people who have suffered an injury and are regaining their conditioning. We can go through the remedial movements of these slides, but these can also be used as an exercise and a strengthening movement pattern. This remedial movement pattern is necessary to gain the range of motion of the ankle and foot complex. Remember our discussion of the mechanics of this complex and the chain reaction that occurs throughout the foot, leg, and hip. If ankle dorsiflexion is limited in motion, there will be suboptimal loading of forefoot abduction, tibial internal rotation, and calcaneal eversion. This will impact the hip, low back, and mechanics of the thoracic spine. We can use the ankle mobilization with other movement patterns such as an overhead opposite reach as an arm driver. We can do step downs to increase ankle dorsiflexion, and we'll be even able to add pivotal toe touches. Wall patterns are a safe and controlled motion that will assist to mobilize the foot, ankle complex, and hips. Imagine a clock on the wall with 12 o'clock and 6 o'clock representing the sagittal plane, 3 and 9 representing the frontal plane. Make sure the motion is captured through the ankles and the hips. Do not think that 12 o'clock to 6 o'clock is only for the right-sided motions and 6 o'clock to 12 o'clock is only for the left-sided motions. Reach to the opposite side, not only for opposite lateral reach, but this will enhance transverse plane motion as well. Start movements at shoulder height, then add the vertical angulations to get more sagittal loading throughout the entire system as these movements are performed. Essentially, wall bangers are a rotational squat that is performed in a safe and controlled environment. The goal of this pattern is to gain mobility while building eccentric strength and loading. As the client reaches during the squatting action, the hip will adduct and bang against the wall. Make sure the motion is coming from the foot and ankle complex and hips. If there is a mild discomfort in the knee closest to the wall, turn that foot inward about 5 degrees. This should reduce that problem. When the hips become more mobile, then gradually move the foot towards a more neutral foot placement position.
For lower extremity progressions, we typically start with a remedial movement pattern such as wall patterns and wall bangers. The rationale for that is to make sure we get adequate motion in the foot and ankle complex, the hips, and the thoracic spine. Likewise, those are very easy for people to apply. It's a safe and controlled environment, and then we're able to capture the motion that's needed for the more advanced techniques, such as a squat. Now, traditionally we do a bilateral squat. We do a neutral stance where we have a bilateral stance. However, I'm not saying not to do them. They're very effective. They do give us the strength that's required to progress forward. However, in an athletic environment, in activities of daily living, there's very little that we do in a bilateral stance. From that bilateral squat, we'll go into an asymmetrical squat. Now we see that the pelvis, this lead pelvis in the forward leg is going to be slightly posteriorly tilted to the trail leg, which is going to have a slight anterior tilt. Now we're at a base of support. We're at a more athletic stance. It's going to allow us to have more power and more adaptability and reactiveness. So we'll do a squat from this position, going forward, coming back with various reaches. What this will allow us to do is get not only the lower extremity and the glutes, but the adductors and the pelvic floor become very reactive and conditioned when we start doing movements such as this. Just like the movement spectrum, where we have narrow and wide in the frontal plane, we have bilateral and staggered in the sagittal plane, internal, external rotation in the transverse plane. We now apply those principles to these particular movement patterns. From there, we'll go into a triplane lunge. We've got anterior tilt. We've got a forward lunge. We have frontal plane lunges, where we'll go into various positions. We'll do crossover lunges, and we will go into rotation. Once we go into the rotation, we start seeing transverse plane motion. From there, we'll start adding verticality for step-ups. And we can do triplane lunge in all three planes. We can even go into rotation and then back down. And then the last part is starting from up high and going into our triplane lunge, sagittal, frontal, transverse. That's typical progression of how we'll start using lower extremity to the traditional movements of training. The shoulder girdle comprises more of the humerus, the clavicle, and the glenoid itself. We also have to consider the sternoclavicular joint. When we look at shoulder function, and particularly when people present with injuries to the shoulder joint itself, the last place I want to look at is what's going on at the shoulder joint, but what's going on with the rest of the body. Because the shoulder is greatly impacted by what goes on at the hips, and the hips are greatly impacted by what goes on at the foot. The shoulder joint, of course, we know works in three planes of motion. In the sagittal plane, there's a huge relationship of the hip with the shoulder joint and the scapular motion itself. So if you would stand up and just stand loosey-goosey, let your arms hang nice and loose at your side, and if you flex forward, as you flex forward, you're going to notice that your scapula is going to protract. Scapula is going to protract and elevate a little bit. As you go into extension, the scapula is going to retract a bit. So when we look at scapular movement, flexion and extension, when you go into extension of the hip, the scapula is going to retract. That's going to enhance shoulder girdle or shoulder joint movement. When you flex forward at the hip, the scapula protracts, which is going to have an impact upon shoulder joint movement as well. So we could say that as the same side hip flexes, that will enhance scapular protraction and elevation and allow the shoulder to extend. You will see that people who have problems extending the shoulder, and if you assess their hip, very often they don't get into good hip flexion. Likewise, the same side hip that extends will allow the scapula to retract and will allow better shoulder flexion. So the same side hip in the sagittal plane that extends enhances shoulder flexion. The same side hip that flexes will enhance shoulder extension. In the frontal plane, let your arms hang loosey-goosey again. And just have your hips go side to side. And this time, just let your left hip go into adduction. You will see that the right scapula protracts, the left scapula will retract. What this will enhance is the same side hip that adducts will enhance same side shoulder to protract and then abduct. So again, we want to see the motion of the hips to see what kind of motion you can get as the same side hip adducts that will enhance same side shoulder abduction, or look at it another way, the opposite hip that abducts will enhance opposite shoulder abduction. Many times when I have clients that have presented and they have impingement issues, they're saying they have discomfort when they go into abduction. Last place I'm going to look is the shoulder. First place I'm going to look is what's going on at the hips, and then I need to see what's going on at the thoracic cage. In the transverse plane, we can look at shoulder girdle function in relation to the hips, that the opposite hip that has good internal rotation will enhance internal rotation of the opposite shoulder. Or we could say the opposite hip that externally rotates will enhance external rotation of the opposite shoulder. You take a golfer that goes through external rotation, or the follow-through internal rotation affects internal rotation. That will have an impact upon shoulder girdle function. When we correlate it to the flexibility highways, in the sagittal plane, the same side hip that extends will enhance shoulder flexion, goes through the anterior flexibility highway. The same side hip that will flex will enhance shoulder extension, will go through the posterior flexibility highway. Then you've got the frontal plane through the lateral flexibility highways, and then through the transverse plane you've got anterior X factor, posterior X factor. Many times when I see people who present with shoulder issues, particularly throwers or tennis players, I'm looking at the hips. I'm looking to see how the hips are functioning, to see how that's affecting the thoracic spine, but then I have to step back and ask, if there is tightness in either region, I have to then go back and say, why? Because we know through our learnings that the hips are greatly impacted by what goes on at the foot. So I've got to make sure that I see what's happening at the foot function. I have to see how that's affecting the hips, the thoracic spine, and ultimately the shoulder girdle.
Each athlete that has been in a rehabilitation setting must go through a battery of tests to determine their physical and biomechanical readiness to return to play. The following sports performance test assesses each person in all three planes of motion. The criteria to allow the athlete to return to play is based upon a result that is comparing the affected region to be at least 90% of the unaffected region. The determination of results is based not only on the quality of the outcome, but the quality as well. Not only are distances and times compared from one side to another, but also a close assessment of the quality of movements, compensations, and efficiencies are viewed. The closed sprint circuit. This test is executed by running a set distance and stopping on the unaffected leg, and then run it again while stopping on the affected leg. If the quality of movement of the foot and ankle, hip, and torso is good, and the time is within 90% of the unaffected leg, then the athlete passed this assessment. In the anterior hop test, stand on the unaffected leg and hop forward for 10 yards or meters. Count how many hops it takes to cover that distance. This can also be done by performing a set number of hops and measure the distance. Repeat with the affected leg. If the distance is covered is 90% or greater to the unaffected leg, then the athlete is ready to return to prepare for competition. Watch for the quality of movement through the foot-ankle complex, hips, and thoracic spine when comparing one side to the other. In the rotational hop, stand on the unaffected leg and hop forward while rotating to the left. Then on the next hop, rotate back to the right for 10 yards or meters. Count how many hops it takes to cover that distance. This can also be done by performing a set number of hops and measure the distance. Repeat with the affected leg. If the distance covered is 90% or greater to the unaffected leg, then the athlete is ready to return to prepare for competition. Watch for the quality of movement through the foot-ankle complex, hips, and thoracic spine when comparing one side to the other. In the posterior hop, be cautious with this test as it loads the posterior chain and quadriceps very dynamically. Stand on the unaffected leg and hop backwards for 10 yards or meters. Count how many hops it takes to cover that distance. This can also be done by performing a number of hops and measure the distance. Repeat with the affected leg. If the distance is covered is 90% or greater to the unaffected leg, then the athlete is ready to return to prepare for competition. Watch for the quality of movement through the foot-ankle complex, hips, and thoracic spine when comparing one side to the other. The lateral hop is a very effective test, particularly in the frontal plane. Be cautious with this test as it loads the knee very dynamically. Stand on the unaffected leg and hop laterally in both directions for 10 yards or meters. Count how many hops it takes to cover that distance in each direction. This can also be done by performing a set number of hops and measure the distance. Repeat with the affected leg. If the distance covered is 90% or greater to the unaffected leg, then the athlete is ready to prepare for competition. Watch for the quality of movement through the foot-ankle complex, hips, and thoracic spine when comparing one side to the other. It is critical to maintain the following key points to attain maximum efficiency, power, and speed when doing movement prep and agility drills. 1. Stand tall. 2. Maintain the stand tall position while holding 90-degree angles at the ankle, knee, and hip. 3. When accelerating to stop or change directions, it is important to hold your angles. As you decelerate, imagine there is a bug underneath your great toe and first metatarsal head. Squash the bug as you slow down and cut towards a different direction. This will engage the leg and gluteal complex to allow greater force to slow the motion. As in the movement prep video, the same principles apply. 1. Stand tall. Stand tall from the greater trochanter to the top of your head. Reach your head to the sky. 2. Maintain the stand tall position while holding 90-degree angles at the ankle, knee, and hip. 3. When decelerating to stop or change directions, it is important to hold your angles. As you decelerate, imagine there is a bug underneath your great toe and first metatarsal head. Squash the bug as you slow down and cut towards a different direction. This will engage the leg and gluteal complex to allow greater force to slow the motion. Up next is movement training for special populations, and we will discuss strategies for those afflicted with many common maladies that the clients of professionals, the fitness professionals, present with. We're going to limit our discussions to back pain, knee issues, shoulder problems, piriformis syndrome, and also iliotibial band pain.